So what are the geriatric syndromes? So we have a Benjamin West painting here of Adam and Eve taking maybe a trip or slip fall. We don't know for sure, but it's important. And CMS actually expects that providers will ask annually whether the older adult had fallen in the past 6 months. We like to find out if they've fallen as a geriatrician within the past year, particularly if they've had 2 or more falls. But also what counts is fear of falling. So if somebody is fearful of falling, they have a very high risk for falling in the future. And likewise, you want to ask if they themselves have any concerns about gait or balance. And I want to point out this Medicare Merit Incentive Payment System, the so-called MIPS, have different metrics for quality outcomes in older adults. And one of those is to ask if somebody screened or said that they fell in their clinical exam, that they then proceed to a multifactorial risk assessment for that positive fall history. And it's important to not only look at the intrinsic elements of falls, such as their wobbliness or gait imbalance, excuse me, but also asking them about extrinsic factors such as things at home that might cause falls, such as lack of slip or anti-slip guards on the shower or bathtub, as well as throw rugs in the house that might be cause for trip falls. So the other geriatric syndrome is incontinence, and basically it's just a screening. It's kind of an embarrassing topic, particularly for women, so it's not always their first thought when they come into the clinic, then say, oh, I've got bladder problems, because generally there's kind of a bias, it's kind of ageism that urinary incontinence is supposed to be normal with increasing age, and it's not. So these are some of the questions that you want to consider and ask. Do you ever leak urine when you don't want to, or are you coughing, exercise? And then this one's always big on going on to the way to the bathroom. I always ask whether the individual gets up at night and has some accidents. Enuresis is not such a big deal in older adults, but also that could be another point of inquiry. Well, the big one in geriatric syndromes is cognitive status. So we want to use our screening tools. The quickest one is the Mini-Cog test for memory, and then also the PHQ-2 for depression. And I think most folks are pretty much familiar with those 2 tests. In terms of geriatric syndromes, we want to screen for neurosensory loss, so vision and hearing screen are important. It's a requirement for the initial annual wellness exam by Medicare. And I pointed out earlier that Medicare does cover glaucoma screening, at least initially. And the other point is that audiometry is the gold standard for neurosensory hearing loss, but the whisper test is pretty predictive. And so that's where you stand behind the individual 2 feet and whisper a letter and a number, and you ask them to repeat that. We'll also want to consider screening for geriatric mistreatment. So 2 components here. One is elder abuse, and those might be identified by unexpected or ecchymoses, contusions, burns, bite marks, and genital rectal trauma, as well as pressure ulcers from sitting around, which includes, by the way, heel pressure ulcers that may not have broken open but have softness on the bottom of the heel. And if they have low BMI, these should all be considerations for mistreatment or self-neglect. And I point out Diogenes syndrome, which is one of the more interesting syndromes that we see in geriatrics. These are people that typically are hoarders and are very homebound. They collect anything from cats and books. I had one patient who collected photographs. He was 96 years old and had about 96 years worth of photographs stuffed in at least a couple hundred boxes that were in his Chicago apartment. In terms of social determinants of health, there's a very good scale for loneliness called the UCLA Loneliness Scale, which would be a good tool that I would endorse. You also want to ask individuals if they have any concerns about their money, particularly if somebody has taken their money unexpectedly, and again, if they have cognitive dissonance or memory loss, they may also have paranoia or delusions about people taking their money, as well as authentically somebody did actually take their money. Most oftentimes it's an adult child who wipes out the bank account, and that all needs to be interrogated and followed up either through your own efforts or through a referral to social work, and then through the Department on Aging for elder abuse. In terms of safety check, I think it's important we mention about home environment, looking for anti-slip for the tubs and showers, and also looking for trip hazards. Kind of reminded of this Edgar Degas painting here that shows a woman bathing in a shallow tub, obviously with no anti-slip devices there, no handbars or rails. So that probably would qualify as a bad situation in the geriatric assessment. Also, you want to inquire about assistive devices. So cane length, does it go up to their wrist and no higher? And then also, if they do have assistive devices, do they actually use them? A lot of patients will come in and they'll say, oh yeah, I have a walker, but it's in the closet. You also want to have carbon monoxide and smoke detectors. Make sure the batteries are updated. It's also important to point out to the older adult that their hot water heater not be above 120 degrees Fahrenheit to avoid burns. And then also importantly, consider driving assessment. Typically these are done by occupational therapy, but also you can refer to AARP for their safe driver course, which would be good, but also the driving assessment needs to go hand in hand with the cognitive assessment. So if somebody screens positive for the mini-cog test, you really then need to drill down in terms of what their driving inclinations are, whether they've given up the keys already, limited their driving, or still continue to drive. Well, kind of a busy slide here with immunizations, and I think I just want to bring your attention to a couple of points here, because you can get all this information from the CDC guide for adult immunization, and you should consult that annually because it changes in some respects. So influenza is important to have and prescribed annually. The high dose influenza shot is generally preferred in the 65 and older. The new recommendations for the COVID-19 vaccine, so currently it's one set, whether it's the RNA with 2 doses or the alternative versions with 1 dose, and the follow-up needs to be determined as of when this presentation was put together. The other point that I want to make out here is with the pneumococcal vaccine. So basically there's a couple of options, but basically you want to give 1 dose of the 23-valent vaccine unless it was given prior to the age of 65. Sometimes people with lung disease are given pneumococcal vaccine in their 55 to 60-year range, and so then you would want to repeat that. But a discussion needs to be made with the individual about the 13-valent and the 23-valent given consecutively. And if somebody wants that higher booster effect, then they need to be given in a sequence of the 13-valent first, and then 1 year later with the 23-valent. You can actually reverse them, but it just depends. Like I say, there's some controversy about the overall efficacy of having both immunizations. But minimally, you would want to do the pneumococcal 23-valent. And then you can see here with the other immunizations, hepatitis, Haemophilus, and so forth, those are generally reserved for individuals that have asplenism, and then immunosufficiency, including people on medications that are part of the complement inhibitors. In terms of chemoprophylaxis, there's a drift away now from aspirin as primary prevention in the older adults. However, if they do have a 10% or greater cardiovascular disease risk, then mini-dose aspirin is recommended in the what I call the young old. So those would be individuals, at least in a geriatric practice, 65 years to up to 70. In terms of vitamin D, the American Geriatric Society recommends 1,000 units, international units daily, and 1,200 milligrams daily of calcium. There is some controversy about taking calcium, particularly in women, is causing some additional problems that are vascular in nature. So it's important to follow up with the randomized controlled trials that address that issue. However, I would just point out that most diets pretty much have about 1,000 milligrams of calcium in them daily. So supplementation would be, to get that 12 to 1,500 mark, would be basically for women 2 small containers of yogurt daily. There's no evidence that multiple vitamins have any impact on functional longevity or just lifespan. However, there is some evidence that vitamin E may lower lifespan, and so I always point out that be careful with vitamin E supplementation. This is a very popular supplement in some of the anti-macular degeneration preparations, and so I often look to see if people are taking multiple vitamins, particularly things like Ocuvite or these other I-type multiple vitamins, and if they're also on anticoagulants. There might be some interaction with vitamin E as well as with fish oil, and then in addition to some of the anticoagulants like Coumadin and apixaban. In terms of hormonal replacement, it's not recommended. So testosterone does not work in men. It basically peters out in 3 months. So they might have an initial boost in their improvement in symptoms associated with testosterone deficiency, but then it doesn't sustain itself. In terms of estrogen and progesterone replacement in women, it's associated with increased cardiovascular disease, although I have to say that there is some evidence that estrogen replacement may be beneficial in brain function, and so there's still continued research in that area. So it's really important to try to get a handle on the lifespan of the individual. One of the better reference tools is what's called ePrognosis. This is from the University of California at San Francisco. And you can go to the site, you can just Google ePrognosis. And here's an example. So what I did is I put in a pretty much healthy 70-year-old male, and accumulated some points. You know, male gender, you get more points, and age, obviously, you get more points. And you can see what the relative 5-year mortality, 10-year mortality, and then 14-year mortality might be. And so sharing that with individuals might be important, because, you know, talking about 1 out of 4 chance of passing away within a 10-year period might stimulate some thoughts about, well, you know, not too bad, but maybe I should get my advanced directives in order, and so forth. So these types of screenings are, I think, valuable for engaging in talk about what matters to the older adult, and also to start looking at their advanced directives. And quite honestly, the sooner the better. You know, everybody should have advanced directives, but as people start approaching 75 years of age, there should be 100% of those individuals with advanced directives.